Our next talk will be delivered by Dr. Timothy Pohlman. Tim is a longstanding member of the chest wall injury community. He has a length of credentials as long as my arm. I'm going to, in the interest of time, I'm just going to say he's a really great guy and a good friend, and he's going to give us a great talk.
Thanks, Tom. Oh, good afternoon, everybody. I guess I'm first thinking or guessing that you might be wondering why we're even talking about this. I mean, generally you go for a position, you fill out a ridiculous form, check chest wall surgery, and you're good to go. And frankly, I felt the same way when I got tagged with this talk, but when I dug down deeper into it, there's many nuances and complexities here. And I'm going to give you my first warning, and I want you to listen to this carefully. If we don't do this right, if we screw this up, this has the potential to set back everything that's been gained in the last 5 years for CWIS. And I mean that. So let's go through this real quickly. The objectives here are, I'm going to lay the groundwork for creation of consensus guidelines that delineate justify requirements for privileges for SSRF and SSFF and chest wall reconstruction, and then determine how to bring this all about. First, I just quickly want to introduce you to my mentor, Dr. Belzer, and the 95-5 surgeon rule. About most of us, 90% are safe, technically adept, competent surgeons. Some of us, 5%, never get it and never will. Hopefully they wash out in residency. And then there's among us, there are 5% recognized to be truly gifted. And Dr. Belzer was really that gifted surgeon. I mean, he would sew a renal vein of a transplant to a common iliac vein just beautifully, just like a machine. And I looked down at it and I said, Dr. Belzer, that's beautiful. Can you teach me how to do that? And he says, Doctor, you cut like a baba and you sew like my half-blind grandmother. I can teach you nothing. But I endured that insult just so I could always scrub with him. And the day before I finished my residency, Dr. Belzer summoned me to his office and he said this to me: "You are a fool, doctor, if you believe you have finished. You are only half done." Now, come on, residency is like prison. You know the day and the hour you get out. I wanted to stick needles in my eye. But for the past 5 years, I've taught you when to operate, how to operate, and the way you manage patients after you operate. In the next 5 years, you must find an experienced surgeon, a mentor, who will teach you when not to operate, who will help you out of trouble, and will show you the minefield you never saw when you were a resident. The most important thing he said, though, was, and then, doctor, you will in turn give back everything that was given to you. So let's be perfectly clear. We're going to talk about not so much preceptoring, that's what you're doing when you're a resident, and kind of in an apprenticeship type program, but proctoring and mentoring. And these three terms, unfortunately, are used interchangeably, but they have very kind of specific meanings. Proctors, they kind of perform a summative assessment of individual for requested knowledge and to perform particular procedures. They're usually solicited by department chairmen, division chiefs, to assess how a surgeon is progressing in a particular chosen operation. And the assessment, of course, must be accurate, rigorous, thorough, and defensible. Proctors often participate. They don't participate in the procedure, and do not provide guidance. I want you to keep that in mind for when we get a little bit further on. And they must possess, obviously, expertise relating to the procedure and be able to conduct the assessment with a high degree of validity. They should undergo rigorous training, plus minus on that. Most important, they're not exposed to they are exposed to very minimal medical legal risk, because this is a peer review process, like Ron talked about a minute ago. Mentoring is a little bit different. Mentors are accomplished leaders with highly respected technical expertise, extensive experience, salient personal skills, and exemplary professionalism. Mentees define goals and objectives, and then you seek out mentors to help them achieve those goals. Mentor and mentee gain immeasurably. The mentee benefits from the expertise of the mentor, guidance, technical, and even in advice on career moves. The mentors benefit by intellectual stimulation and watching the mentee emerge, although I don't think Dr. Belzer really enjoyed being my mentor. Relationships between mentors and mentees evolve over time and become more collaborative and more like partnerships. That's published there. There are two types of expertise in surgery that are recognized. General expertise is characterized by pattern recognition, rapid and effective decision-making, fluency of actions, and efficiencies in performance. Adaptive expertise is basically how do you respond to the unknown, to the unexpected, and adapt to a situation that you didn't expect. There are different paths to chest wall privileges. A surgeon seeking to acquire privileges to perform procedures learned in formal training but are outside core surgical privileges. A resident that did a number of cases, chest wall surgery as a resident, can produce a case log, and then applies for privileges as he or she would, applying for general core privileges. Then there's a surgeon that's by his or herself and acquires privileges to perform procedures that developed after residency. So kind of the surgeon in a level 2 trauma center who there's no one else there doing these types of procedures. And that's Latin for the word that best close resembles by himself. And then there's a surgeon who's is within a group, some with varying degrees of expertise on chest wall surgery, and that's a pathway to privileges. And I only point these out because this really complicates the kind of proposal or recommendations that we would ever put out. So let's kind of dig down on this a little bit. So let's imagine you are surgical chief of a 400-bed hospital, which is the American College of Surgeons verified level 2 trauma center. You are informed that one of your trauma surgeons, who is 6 years out of fellowship, seeks privileges to perform surgical stabilization of rib fractures and sternal fractures. You are a neurosurgeon and know nothing of thoracic surgery. You have never heard of surgical stabilization of rib fractures. None of the other trauma surgeons, nor any surgeon on your staff, performs these procedures. In fact, one surgeon considers it unnecessary surgery and quite often says so. Alas, this ambitious young surgeon has never done one either. However, he or she professes participation in a day-long industry-sponsored course that included a long morning of PowerPoint presentations by recognized experts and an afternoon in a loosely structured hands-on cadaver lab where the major topic of discussion was how much time does it take to get to the airport and an airplane and a ride home? What should you do? Think about that for a minute. Or imagine this. You are surgical chief of staff at an 800-bed hospital, verified level 1 trauma center. You are informed that one of your acute care surgeons, who does 50 to 75 cases a year, is seeking internal funding to train the other trauma surgeons in the art of SSRF. This SSRF superstar is director of the hospital's notably successful and profitable Chest Wall Injury and Reconstruction Center. He's a prolific author. Industry execs listen to his every word. Most of all, he's considered a preeminent member of the nationally recognized, highly regarded CWIS mentoring program. It doesn't get any better than this. You are aware, however, that the other trauma surgeons are all self-absorbed, self-indulgent young men and women who are guided by their secure belief that team play is mostly, if not completely, unnecessary. Consequently, you predict the proposal before you is doomed and should not be funded. How do you handle this? Where do you start? So I'm kind of making fun a little bit, but these are real life problems. And these are the things that we have to kind of build in to make these to do this right. So we start with the American College of Surgeons, statement on credentialing and privileging and volume performance issues. Occasionally, the college manages to recognize the obvious and does it poetically sometimes, and recognizes that new technologies come along and training develops after residency, and then they make a kind of a vague statement that gets us nowhere until it's booted to the Division of Education, and they define principles for learning new surgical procedures in the course of applying for privileges, which includes mastering of didactic content, technical training on an inanimate model, including cadavers, proctored incorporation of the new technique or technology into practice, demonstration of safety patient outcomes, satisfactory patient outcomes, and focused professional practice evaluations, what Ron talked about, FPPEs are required. The ACS tacitly assumes that if you develop criteria for privileges that follow these guidelines in the training component of that they will they consent to authorize or informally authorize for use locally and not nationally. So what we'd like to do is go to the CWIS page, and hopefully in one of these drop-down menus, there would be a point or something that could be clicked on, guidelines for surgical privileging, which would take you to a page that has those different kind of pathways and how to do it. And don't try to read these necessarily. We'll go to the next slide, which shows what qualifications are needed to surgically manage chest wall injuries. So let's say first one must, of course, hold core surgical privileges. That goes without saying. Then one must successfully complete a CWIS-defined training program, which shall include, but not necessarily be limited to, online training modules. And I've just kind of came up with 5 quick ones as an example. These you would complete online and pay for. And then would there be a center site visit? In other words, a person that's trying to learn how to do SSRF, go to a site and watch the procedure being done, how the cases are set up, how they're worked up, and how they're followed postoperatively. I put that in red as a question mark more than anything. There should be a 1-day non-industry sponsored cadaver lab stimulating real cases where the cadavers, I hope, would be set up to represent cases that would match like something on a 3D that would be associated with the cadaver, so that they have to plan approaches. And then how many proctored cases should they perform? How many? And I think this is just a draft, and I want to make sure you understand that. There are significant issues here, though. Regarding core privileges, should these also include non-cardiac thoracic surgery procedures? Should we include chest wall resection and reconstruction with SSRF and SSSF? Proctoring is the biggest issue. How do we proctor somebody that's doing the first case, the second case, and how many? How many cases should be proctored? 5 cases? 10? Or how about 1 case and maybe a second if the first one doesn't go well? How exactly do we pull this off? I mean, like who's going to pay for all this? And should we develop so-called teleproctoring capabilities? I want to spend a little minute on that. What about outcomes? How do we get to handle on that? And what should we put down for maintenance criteria? Should mentoring be mandatory? I just want to finish up with teleproctoring. This is the new thing thanks to COVID-19. You want to say, hey, yeah, this is great. This is really the answer. This is the way we can do it. Teleproctoring simplifies scheduling and reduces the time delay in scheduling a procedure. Proctors are spared the astonishing misery of commercial air travel. Telecommuting could be cost-effective by hospitals and sponsoring companies, reducing proctor expenses. As it advanced with with development of breathtaking, almost unbelievable capabilities. And there are certain cameras that have been designed by other services that help with visualization of the operative field. This is just one example. The way not so fast, I mean, teleproctoring carries unique, if not formidable, set of technical challenges. It must generate a high-speed, high-fidelity, encrypted transfer of data by reliable bidirectional transmission with negligible latency. If you're teleproctoring, you have to be, you need unimpeded communication between the surgeon and the proctor. And the proctor must be completely spatially and situationally aware, and must be able to assess in real time. Operative field visualization is problematic, and I think for chest wall reconstruction, that would be the case. And satisfactory hardware and software is required, the cost of which is not unsubstantial. These systems must be able to interact with a myriad of different hospital telecommunication systems, and probably won't all the time. And small issues like Max and Citrix, which is the VPN sort of basis, don't generally get along, at least not in my Mac. But teleproctoring, how much is lost though in not actually being there? And this is kind of my last example. Picture an OR filled with OR staff, baffled, unsure, anxious, wondering about this new thing Dr. Smith has brought to their hospital. There's palpable tension and doubt in the air. Dr. Smith walks tall and appears confident, but this belays an intense underlying fear of failure. What was I thinking, he thinks. The anesthesiologist is fuming. The CMO has got himself into scrubs and is in the OR, and deep suspicion about SSRF is in his eyes. And then Tom White walks into the room, full of confidence, full of grace, full of charm, full of credibility. I mean, doesn't that just kind of repair the situation? I think so. Okay, lastly, how do we bring this about? Well, I think we bring this about the way we've gotten lots of things done. You know, form a committee or working group or something like that. Make Andy Dobin be the head of it. Yeah, I love you, Andy. I was on the plane, I was thinking, no, here's Andy's, you know, he's president-elect, he was acting chairman of the board, he was acting of several committees. And I thought about it, should I really do that? And he can do it. In closing, I leave you with this warning, second warning. These non-core surgical privileges applications can become, for no good reason, intense, all-consuming political battles fought at the highest levels. The privilege part of these battles are just pawns in a game of negotiations. As always, it helps to be connected. For example, the chair of our credentialing committee and I were med school classmates. And we are buddies, we frequently golf together. We generally can get a deal done by the third hole. Never forget, the politics of academic medicine are so vicious because the stakes are so low. Thank you. Enjoy the rest of the summit. I'm sorry, any questions?